Thank you, the organizing committee for my invitation. Can you see my screen?
Yes.
Sorry.
Yes.
Yes. That's good. So,
Can.
okay. So today I'm going to talk about the anatomical point of view of open surgery and endoscopic surgery for the third ventricle. I have nothing to disclose. My pictures I did during a fellowship with Professor Rotten. So on this, to start with these axial cuts, we can see that the brain has 4 ventricles. It has 2 large ventricles, one on each side, called the lateral ventricles, and 2 unique odd cavities, the third ventricle between both thalami and the fourth ventricle on the posterior fossa between the pons anteriorly and the cerebellar vermis posteriorly. Both lateral ventricles, they are separated by this membrane that it's actually 2 membranes fused together. It's called the septum pellucidum. And the lateral ventricle, it's usually subdivided into its extensions or horns according to their position in relation to the thalamus. So the anterior horn is positioned anteriorly to the thalamus. The body of the ventricle is superior to the thalamus. The atrium is posterior to the thalamus. The posterior extension of the atrium is called the posterior horn, and the inferior horn is inferior to the atrium. Both lateral ventricles are separated by this membrane, this is the septum pellucidum, which can be divided or punctured during microsurgical or endoscopical approaches. It's a common neurosurgical procedure. And then after the lateral ventricle, the CSF drains into the third ventricle, this cavity between both thalami. This is a medial view where we can see here at the center of the image, the foramen Monroe, which carries the CSF from the lateral ventricle towards the third ventricle. Then from the third ventricle, CSF will drain through the cerebral aqueduct into the fourth ventricle. The thalamus makes the lateral walls of the third ventricle, one on each side. Inferior to the thalamus, we have a very shallow sulcus that comes from the foramen Monroe towards the aqueduct. It's called the hypothalamic sulcus. Superior to the sulcus, we have the thalamus. Inferior to the sulcus, we have the hypothalamus. The hypothalamus is more like a region than a structure. It's composed by the superior aspect of the mesencephalon, then mammillary bodies, tubercinarium, infundibulum, and optic chiasm. The anterior wall of the third ventricle is formed by a membrane, the lamina terminalis, that comes from the chiasm to the anterior commissure. And the posterior wall of the third ventricle is formed by the epithalamus, which is centered at the structure, that's the pineal gland, attached to the posterior wall by through 2 arms, one superiorly that attaches to the abenellar commissure, and one inferior that attaches to the posterior commissure. And there is a ridge here called the stria terminalis that we are going to talk about this later. Then from the third ventricle, it drains into the fourth ventricle and then opens into the subarachnoidal space. The lateral wall of the third ventricle, which are made by the thalamus, the thalamus is really part of a big concept called the central core. The central core, it's a block of structures that have all different origins, but morphologically they can be put together and all make the lateral wall of the third ventricle. We have here the insular surface, then the extreme capsule, claustrum, external capsule, lentiform nucleus, internal capsule, caudate nucleus, and thalamus. What is important for us to note is how close the genu of the internal capsule that carries the pyramidal tract that will supply the face, so the corticonuclear tract, how this relation is very close, this anatomical relation is very close to the foramen Monroe. So keep this in mind, we're going to come to this later. When reaching the third ventricle, the surgeon first usually needs to reach the lateral ventricle. To reach the lateral ventricle, the surgeon can come interhemispherically through a transcallosal approach and then move forward to a transchoroidal approach, or he can go transfrontal. To come first into the lateral ventricle through an interhemispheric approach, he will first build his craniotomy, looking for a point when he will not have a lot of bridging veins. Usually he will do this craniotomy near the coronal suture because there is a relatively paucity of bridging veins at that point. The bridging veins can drain at the superior sagittal sinus into several separated veins or into a one big unique vein. The surgeon has to pay attention to this, to dissect the vein and open this gap between these two bridging veins without hurting or overstretching these veins. Here we can see that how easily it can be overstretched. Then he will go deep inside the interhemispheric fissure, open the supracallosal cistern, paying attention not to harm the cingulate gyrus, but yes, to identify the very bright corpus callosum, and he will make the callosotomy. Where he's going to make the callosotomy in the adult, the point where the callosotomy will reach the foramen row is usually 2.5 centimeters posterior to the genu of the corpus callosum. Another anatomical place to consider is where the paracentral lobule is. In the adult, it's usually 5 centimeters posterior to the bregma. It's a point called the superior Hollandic point, and the surgeon needs to pay attention to this, not to put his spatula over the paracentral lobule. Then he can carry on with the callosotomy, open the corpus callosum, and reach the lateral ventricle and identify the foramen row. To locate himself inside the lateral ventricle, he will look for the anterior septal vein, which is attached to the septum pellucidum, and to the thalamus striate vein, which is located between the caudate and the thalamus. And in the other point of view, if he goes transfrontal, he can go it microsurgically or endoscopically. One point to consider is the connection between the superior frontal sulcus with the precentral sulcus, which is usually a cisternal point, and the adult 2 centimeters posteriorly to the coronal suture and 3 centimeters off midline. He will locate this point. He can open the superior frontal sulcus microsurgically, or he can put his endoscope through there, and if he goes circumferentially towards inside the brain, he will reach the lateral ventricle. This approach will harm first the U fiber, the short connection fibers between the gyri, which has not been related to functional deficits, and will also be medial to the superior longitudinal fascicle that carries the arcuate fascicle. So he will not harm language functions as well. Once inside the lateral ventricle, he will reach the third ventricle by some corridors. He can reach through the transforaminal approach, which he will just go into the foramen row, paying attention not to harm medially the fornix and not to harm laterally the genu of the internal capsule. This is a nice preparation where metal was put inside the cerebellar cavities, and you can see how the transforaminal approach will reach the third ventricle in midline. If he goes transchoroidal, he needs to understand what is the choroidal fissure. The choroidal fissure is where the choroid plexus is attached, and it is attached laterally by a tenia thalami and medially by a tenia fornicis to the thalamus. This choroidal fissure is the fissure that is the inner C of the limbic system. The limbic system is made by a cortical outer C and an inner subcortical C. The outer C is made by the cingulate gyrus and parahippocampal gyrus, and the inner C is made by the amygdala, hippocampus, and its fibers collect and form the fornix. This is the inner C. Amygdala anteriorly, onchorecess, hypothalamus, and the hypothalamus fibers converging and forming the fornix. Here is the opening of the choroidal fissure, this inner C of the limbic. It's a natural cleft. If it opens superiorly, it will reach the roof of the third ventricle, posteriorly the pineal region, and inferiorly it will reach the ambient cistern. This section is just to show how it really is a natural cleft that can be microsurgically open. If we go superiorly, we'll reach the roof of the third ventricle, passing through the choroidal fissure and getting inside the vela interpositum cistern and then the third ventricle. What is the veno-interpositone cistern? It's a cistern that holds vascular structures. Here's the posterior medial choroidal artery getting inside the veno-interpositone cistern, and the internal cerebral vein draining outside from the veno-interpositone cistern. This is another nice dissection where we can see all the trajectory of the posterior medial choroidal artery arising from P1 or P2, traveling all around mesencephalon, getting superior into the pineal region, and then entering the roof of the third ventricle, the veno-interpositone cistern. So at this route, the surgeon will ideally go through the tinea fornices, so between the fornice and the choroid plexus. So he will make a cut between the fornix and the choroid plexus, a small cut, and will dissect, bring the fornix medially, note the connection between the thalamus striate vein and the anterior septal vein that forms the anterior cerebral veins. He will locate both internal cerebral veins and ideally go between them both and open the roof of the third ventricle. He will reach all the third ventricle. Here he can see the massa intermedia, which is usually common, connecting both thalami. If he projects anteriorly, he can see the prominence of the mammillary bodies and the tuberous cinereum anteriorly. He can cut the massa intermedia and angle his microscope posteriorly to see the opening of the aqueduct and all the floor of the third ventricle. Endoscopically, he will see the same anatomy, but maybe with less freedom of exposure. He will go transforaminal, and here we can see all the floor of the third ventricle seen endoscopically. If he points posteriorly, he endoscope or use an angled microscope, he will also see the recesses on the epithalamus, so on the posterior floor of the posterior wall of the third ventricle. If he goes laterally to the tinea thalami between the choroid plexus and the thalamus, he will also reach the roof of the third ventricle, but this exposure will have the thalamus striate vein on his anterior aspect and will not facilitate the exposure of this anterior part of the third ventricle. So ideally, he has to go more medially and not so lateral as in this other example. He can also go interfornicial, especially if the patient already has a natural split between both septum pellucidum lamina. It's called the cavern of the septum pellucidum. He can go between these both lamina, locate inferiorly both fornices, go medial in the midline, and reach the third ventricle superiorly from the superior point of view. Also noting that he will be dealing with both fornices, so functional deficits can arise from this manipulation. He can cut massa intermedia as well. Another possible approach is to go posteriorly, supracerebellar, through the pineal region, superior to the pineal gland. This is done microsurgically and will lead to the posterior region of the third ventricle. So the surgeon can come midline, but usually he will prefer to go offline because it has this stand appearance, and midline, the cerebellum at midline is higher. Notate that he will have to deal with veins, locate the pineal gland and go superiorly to the pineal gland. This is a midline approach. This is an off midline approach. So here's the pineal gland, and he will go superior to the pineal gland and get inside the third ventricle, superior to the pineal gland, into the posterior region of the third ventricle. Another possible approach to go through the termina terminalis, through the anterior wall of the third ventricle. So he will go through a peterianal approach, maybe a little bit more anteriorly, locate the lamina terminalis. This is this lamina that is stretching from the optic chiasm to the anterior commissure. He will locate this membrane and make a puncture here and get inside the anterior aspect of the third ventricle. An endoscopic approach can be through the sphenoidal sinus, so trans-sphenoidal approach, where he can come through the tuberous cinereum, through the inferior aspect of the third ventricle. And here is what would be this endoscopic view. So he would see massa intermedia in midline connecting both thalami. So all here is third ventricle, both foramen Monroe, superiorly, fornices, and the lateral wall of third ventricle, one on each side, the thalamus, subhypothalamic, hypothalamic sulcus, and floor of third ventricle inferiorly. Okay, thank you once again for the invitation, and I would be glad to answer questions if there are.
Eduardo, Rick Boop.
Thank you, Eduardo, for the experience.
That was a
Yes,
gorgeous lecture. Just one comment: in our experience with third ventricular tumors, we've written on sacrificing, coagulating, and cutting the septal vein just before it comes into the thalamus-striate ICV junction, and that opens the door between the choroidal fissure and the foramen of Monroe. We've not seen any complications from taking the septal vein.
I agree with you, Professor Boop. Nice to see you. And I have actually a slide that shows this relation. If we go more laterally, we will have to deal with the thalamus-striate vein. But if we go medially between both internal cerebral veins, then if we want to go more anteriorly, we will sacrifice the anterior septal vein, and that's what happens. Is it will not happen. You can sacrifice it. So you are talking about the right approach. So go into the plexus, the choroid plexus laterally, and the fornix medially. That's the right way to go. And yes, thank you for the question, Professor.
So let's see if we have questions from the audience. We have a question. Do we have any clinical info on unilateral fornix damage, dominant versus?
Well, through the interforniceo approach, you will have to do with broad fornices. I would see that this is potentially harmful because you are dealing with both sides of limbic structures. Usually the limbic structures can be harmed at one side without major functional deficits. I would be comfortable going transchoroidal and manipulating the fornix, of course not cutting it, but manipulating. I think patients usually don't have functional deficits if you just manipulate. But I've never done interforniceo approach, and I never saw it being done. But I would be, I would note a lot not to harm both fornices.
Okay, thank you. And another question: how many times is truly required to reach the third ventricle through other ways? This is more for anyone rather than the transcallosal way.
Well, if you want to go more laterally into the lateral ventricle, for example, head of the caudine nucleus, you would go transfrontal. Endoscopically, you always go transfrontal. I never seen endoscopic approach at midline. People usually go transfrontal, of course, and then it's a natural way to get inside the lateral ventricle. Then to get forward to get inside the third ventricle, microsurgically you will go transchoroidal, and endoscopically you will go transforaminal, which are more or less the same because the foramen Monroe is really a natural enlargement of the choroidal fissure. So both are transchoroidal, but one is a natural already open transchoroidal approach, right? And the other one you have to open micro